prostatectomy with this new maneuver in the PPH patients. Benign prostatic hyperplasia, it is the most common benign neoplasm. Over 40% of patients over 60 years complaining of lower urinary tract symptoms. 8 persons from 10 patients can be diagnosed by the urinary symptoms like weak stream or frequency, urgency. The worldwide prevalence of the PPH by the age, about 50% of men over 60 years have PPH, and about 8 over 70 years have PPH. The symptoms of PPH is divided into 2 main categories: the voiding symptoms and storage symptoms. The voiding symptoms like hesitancy, straining, weak flow, terminal dribbling, and incomplete emptying of the bladder, double voiding. The storage symptoms like frequency, nocturia, urgency, and the urgent contrast. So what is the resume water vapor therapy? The resume water vapor therapy, it's a minimally invasive procedure which uses the natural energy stored in few drops of water to treat excess prostate tissue causing PPH symptoms. So there is no need to continue taking the costly PPH medication. Why resume is unique? It is unique in 3 categories. Unique heat source, it's coming from water vapor energy. It's unique heat transfer mechanism by convection. It is unique, uses the prostate anatomy, the whole therapy contained within the zonal boundaries of the prostate. So I explain next slide the key point for the technology in this device. It is the transfer, as we see here, we transfer the vapor by convection. It is uniformly spread all over the prostatic cells, so all cells receive this heat equally. But in the conduction, which is present in the ordinary devices for PPH before, it is conducted the heat, but the heat is spread ununiformly. We see here that the near cells near the source of energy is getting hit or burning more than the far cells. So this is the difference between the convection and the conduction, which is present in this procedure. The indications for resume procedure. It's ideal for patients with the prostate size from 30 to 80 grams, and for men who are not willing to take PPH medications, men who are not willing to consider other PPH procedures, and for men whose medical condition is unfit to undergo any procedure under general anesthesia. And also men who desire to preserve their sexual life, avoid erectile or ejaculatory dysfunction. This is the resume device. It is formed of 2 main parts. The generator on the right side, which is a source of energy, and left side, this is the delivery device. The delivery device has port for the lens and have the shaft tip and 2 buttons. These blue buttons to release the vapor, and the gray button to deploy the needle and retract the needle. This is manufactured by Boston Scientific. This is a huge American company. What is the objective of the resume procedure? The objective is to create thermal lesion in the length of the prostatic urethra along each lateral loop. And this is accomplished by distance between the bladder neck and 1 centimeter proximal to the verumontana. And also we targeted the bulk of the adenoma. Also, we give the treatment follow the natural slope of the urethra. We start the procedure by the routine cystoscopy. First, we stop at the veru to assess the prostatic anatomy, and then progress slowly to the bladder neck. Then we retroflex in the bladder. The key point, which is the procedure based on, is to measure the distance between the bladder neck and verumontana. How we measure it? We measure it by what's called field of view. We measure the prostatic length by the field of view. This view, it is the view of delivery device through the optics. And it's about centimeters from the tip of the device to a imaginary line. It's called arm exit, where the device's arms exit the screen. This video, it can show how can we measure this length. This is the tip of the device, and we will pull back for half centimeter for each view. So we have to get 2 views for 1 centimeter. We have to estimate the number of treatments we used in the procedure, and this can be estimated by measurement of the prostate length primary determining factor. What is the primary determining factor? It is the distance from the bladder neck to about 1 centimeter proximal to the verumentum. And according to this estimation of the determining factor, we determine the number of the treatments. If the distance between the bladder neck to the veru is less than 2 centimeters, so we do 1 to 2 injections per loop. If the distance between 2 to 3 centimeters, we inject 2 to 3 treatments per loop. If it's more than 3 centimeters, we inject 3 to 4 treatments per each loop. Then we will go to the next step. After estimation of the distance and after the routine cystoscopy, then we have to place our device. We place the device tip at the bladder neck, and then as this pictures show, we rest the device tip on the bladder neck and then rotate 90 degrees and will back about 1 centimeter from bladder neck. 1 centimeter, it means 2 field of view. Then we stabilize the device and then target the bulk of the adenoma, then deploy the needle at 9 o'clock. This is for the right loop. Then we activate by the press on the blue button to evaporate the vapor and waiting for 9 seconds to activate it. Then we leave the needle inside the adenoma for about 2 seconds, then retract the needle and go to another site. The same done in the left loop, but we rotate also the device for about 90 degrees, but we injected our treatment at 3 o'clock with the same like the right loop. For the median loop, there's different technique, somewhat, and we have to estimate first how many treatments we will inject in the middle loop. If the middle loop it is more than 2 centimeters, we deliver 1 treatment. But if more than 2 centimeters, we deliver 2 treatments. The difference here, the video demonstrates the difference. We rotate the device tip not 90 degrees. We have to rotate it 45 degrees only at 5 and 7 o'clock. And then we deploy the needle, inject our vapor. Be careful here not to direct the needle to the rectum. And also we target the bulk of the tissue. This is 2 videos showed one of the cases about 52 grams prostate. It's pre-treatment and after 6 months. In the left side, we see here the prostate, mainly middle lobe, not 2 large lateral lobes. And the second video on the right side showed significant reduction of the prostate volume after 6 months. So it showed the result of this procedure. Also, these pictures, it showed the simultaneous ultrasound done with the procedures. On the right side, this is the live procedures. Now the device rotated 90 degrees at 3 o'clock. At the same time, we can see on the left side, the picture on the ultrasound, the needle looks by red arrow, injected in the transitional zone of the right loop, and then the vapor released. We can see here the time within seconds, the vapor spread all over the prostate. The vapor is making a denaturation of the cell membrane of the cells, so this will occur. This is the mechanism of what happened for the prostate to diminish the size or to make atrophy for it. This video, it's about 2-3 minutes. It's demonstrate this procedure, what I explained, but it will explain it, demonstrate it clearly, so we can hear and see for just 2 minutes.
Perform the pre-treatment vapor cycle outside of the patient. While inserting the delivery device, assess the anatomy, then follow the prostatic urethral angle and position the tip of the delivery device at the bladder neck. Use the delivery device tip as a starting point to determine the length. The distance from the delivery device tip to an estimated line where the device arms exit the screen is 0.5 centimeters or a field of view. Focus on a spot near midline, then manually pull the device back until the delivery device tip is at that spot. The device has now measured approximately 0.5 centimeters and makes up one field of view. Estimate the vapor treatment zone by measuring fields of view down the natural slope of the urethra between the bladder neck and verumontanum. Start with the delivery device tip at the bladder neck. Rotate 90 degrees, then pull back, stopping at 2 fields of view, and ensure device tip is resting against lateral urethral wall. Stabilize the device, deploy the needle, and press the vapor button. Each treatment is 9 seconds long. The vapor will automatically switch off at the end of the treatment. Then retract the needle. After a treatment, keep the device at 90 degrees so that you can measure another 1 centimeter or 2 fields of view without losing sight of the previous treatment. Ensure to space the treatments approximately 1 centimeter apart. Prior to the final treatment on each lateral lobe, locate the verum to ensure the device tip is proximal. Do not treat the proximal end of the verum. Median lobe treatments are delivered by positioning the device 1 centimeter from the proximal edge of the tissue and angling at 45 degrees medially into the tissue. Do not direct the needle towards the rectum. The number of treatments will be determined by the size of the median lobe. Deliver 1 treatment if the median lobe is less than 2 centimeters and 2 or more treatments if the median lobe is greater than 2 centimeters. The elevated central zone is hyperplastic tissue that progressively inclines toward the bladder neck. An enlarged central zone is treated 1 centimeter or 2 fields of view from the bladder neck, with the needle positioned at 45 degrees medially into the tissue. Do not deliver vapor on the floor of the urethra within a minimum of 1 centimeter from the verumontanum. Remember to not direct the needle towards the rectum. At the end of the resumed vapor treatment procedure, perform a final assessment of the prostatic urethra and bladder, and then atraumatically withdraw the device.
Thank you. So, what about catheterization post-operatively? I think the catheterization, it not less than 72 hours, about 3 days. But anyhow, most of cases, the duration of fixation of the catheter depends on many things. Depends on the irritative symptoms that happened after surgery in the form of dysuria, frequency, urgency. Anyhow, we determine the duration of the catheter depends on the prostate volume, the number of treatment, the median loop, presence of absence of median loop, and the bladder function as a tone. Anyhow, the recovery from this procedure the lower the injection you used, the faster the recovery. I think the more injection you used it, the recovery may be delayed, and maybe the caster stayed or lived for little bit long time. What are the advantages of this procedure? No need for general anesthesia in this procedure. We can do it under local anesthesia. The hospital stay is very low. We can decrease the hospital stay by these procedures, and so we can reduce the cost on the patient. It preserves the sexual function, and this is clear advantage over the other procedures used to PPH. We spare the erectile function, and we can spare the ejaculatory function. Resume is very quick. It may be done less than 5 minutes. Other procedures, the traditional ordinary procedures, may take 1 to 3 hours, and must be done in the operating room. Another advantage is significant reduction in the blood loss during the procedure. Disadvantages of this resume procedure is hematuria, some patients, hematospermia, slight reduction in the sperm count, some irritative symptoms like dysuria frequency, up to retention. Another disadvantage is unavailable prostatic tissue that we used it to histopathological examination. Catheterization may prolong up to 10 days, sometimes 2 weeks. Most of these adverse effects resolved after 3 to 4 weeks. Contraindication of this resume in patients with the penile prosthesis, in patients with the prostatic cancer and elevated BSA. The EUA guidelines in 2019, it was first conditional recommendation, level grade 3. It was recommended for patients with LUTS attributed to PPH, provided the prostate not more than 80 grams. 2020, the recommendation became moderate recommendation, also grade 3, also the same indication, and for these patients who desire to preserve their erectile and ejaculatory function. The summarization, the final comment on this procedure, it's simple. It can be done in outpatient. It is minimally invasive procedure, does not require general anesthesia. It preserves the erectile, ejaculatory, and urinary functions. Most patients show symptoms improvement after 2 to 4 weeks. The ability of the patient to return to his regular activity within few days, and long-term symptoms relief. Thank you.
شكرا دكتور أيمن. في حد عنده أي أسئلة؟
دكتور أيمن بيه، طبعا شكرا على البرزنتيشن الجميلة. كنت عايز بس أسأل حضرتك من خلال الحالات اللي حضرتك اشتغلتها، ايه اكتر كومبليكيشن يعني واجهت حضرتك من الكومبليكيشنز اللي حضرتك ذكرتها، وكانت حاجة يعني مش لطيفة بالنسبة لحضرتك من خلال الحالات؟ يعني هل
Actually we did in our department, we just started this procedure. We have experienced 2 patients. First patient, it's about 70 years old, prostate about 55 grams. He's unfit to do any procedure. So we did it by the resume. We inject about 6 injections, 2 each loop and 2 in the middle loop. The patient, I leave the caster for about 7 days. I remove the caster. Unfortunately, the patient developed retention. So I put the caster again and reassess the patient. I think the patient was have hypotonic bladder. So I leave the caster for more 2 weeks later. I give the patient mistionone to improve his tone, and I remove the caster after 2 weeks later. I remove the caster, the patient urinated very good, and collected the urine for 3-4 days. It's good. I assess the residual urine, it is insignificant. He started to get improvement in the symptoms, mainly the voiding, but still has storage symptoms. What he complained of it before the surgery. And two weeks later, he came to my outpatient. He was very grateful. He showed very good improvement in his urination up to I stop the medication at once. This is the first case we did it. Second one, unfortunately, his BSC was normal and he was unfit, and we also injected by Resume. But he developed renal impairment after that. He developed oliguria. Creatinine start to rise. The creatinine was reaching 6-7. Start dialysis. He was complaining of severe hematuria because he was cardiac. He was on anticoagulants. It is something unexplainable. We redo by Dr. Anwar. He do again recystoscopy. He found just small piece of middle loop. He took it, and after that the patient is not improved. He is not urinating good, and he is not getting well. The creatinine never dropped. Start dialysis, not responding. The back pressure is not improved, and unfortunately we found the pathology that we taken by the second cystoscope, adenocarcinoma. This is unlucky patient because his PSA was normal, so we didn't recognize this cancer before. And of course, in this case, Resume is contraindicated. But this is what happens. We do the patient bilateral nephrostomy, and the antigrade double J start to get well, start to improve, get to normal, and we remove the caster. The urine, the voiding is good. This is our two experienced patients.
Thank you.
دكتور أيمن، أول حاجة البرزنتيشن رائعة. تاني حاجة حضرتك وفيت في الشرح عن الريزيوم، بس أنا كنت عايز أخد رأي حضرتك في الريزيوم. يعني هو بروسيجر جديد، تكنولوجي لسه to be evaluated طبعا، بس أنا كنت احنا دلوقتي النقطة الأساسية إن هو زيه زي أي تكنولوجي بتبقى لسه طالعة جديد، بيبقى فيه ليها تسويق، هنقول كده، على شكل عالي جدا، إن هي ممكن الحل السحري لجميع المشاكل والحل اللي ما بيعملش مشاكل. بس المفروض إحنا بقى يعني كأطباء مسالك عارفين إن الموضوع مش زي كده بالظبط، محتاج good selection للكيسز، محتاج إن إحنا نختار الحالات اللي هي نقدر نقول ان الريزيوم هيفيد، والحالات التانية اللي هي الريزيوم مش هيبقى احسن حل ليها.
I'm totally agree with you. Proper selection of the patient is very important in this procedure. I think the patients who get benefit from this, he must be a little bit young, 50s, because he wants to preserve his sexual life, the erectile and the sexual function. Maybe patient not more than 50-60 grams, because larger than that, it will delay the recovery and will not improve the results. patients unfit for surgery. This is very proper selection for the patient when the patient is unfit, because very fast procedure and we can do it by local anesthesia.
انا متفق مع حضرتك جدا في الكلام اللي بتقوله، لان هو السلكشن ده اللي هيطلع لنا ريزلتس حلوه جدا من الريزيوم. فعلا هناخد الفايده بتاعته للحالات اللي حضرتك بتقول عليها دي، ويبقى نمينيمايز الانفورشنت ايفنتس اللي ممكن تحصل طبعا.
هو
شكراً
كمان في الليترشر بيتقال ان يعني انت قلت في الكونتر انديكيشن البينال بروثيس
Yes.
والريتنشن. Retention is one of the contraindications.
Sorry.
In a patient presented with retention by prostate, it's better
Yeah.
not to do it.
Yes, agree.
شكرا دكتور أيمن.
شكرا.
Let me introduce the second presentation with the title of Retrograde Intrarenal Surgery in Renal Stones, Flexible Ureterorenoscopy by Dr. Muhammad Mohi.
ده فوق ده طب في فيديو مش المفروض هنشوفه عندنا.
انا فاهم، انا ده اللي جه في دماغي. اتفضل يا دكتور محمد.
مساء الخير. اول حاجه احب اشكر الدكتور ايمن وهيدي رئيس قسم جراحه المسالك البوليه، والبروفيسورز موجودين، استاذ دكتور انور حلمي واستاذ دكتور احمد توفيق واستاذ دكتور محمد متولي. وانا عاوز اتشرف النهارده ان انا ان بريف اقدم ستادي على 60 او على 60 patients done over 230 patients underwent flexible ureteroscope in our department between 2020 to 2023. الستادي دي concerning the safety and efficacy of the retrograde intrarenal surgery for renal and ureteric stones. Urinary stones are a public health problem. It's the third most common affliction of the urinary tract, exceeded only by urinary tract infection and the pathological conditions of the prostate. Stones affect around 20% of the population globally, and the incidence of the kidney stones is nearly 13% in male, 7% in females. In addition, about 50% of patients will have a recurrence of renal colic within 5 years of their first episode. In this study, the 60 patients, all patients were subjected to the following: pre-operative assessment, proper pre-operative assessment, such as history taking, clinical examination, laboratory examination such as urine analysis, culture and sensitivity, blood urea and serum creatinine, complete blood counts and coagulation profile, the imaging modalities such as ultrasonography, plan radiograph of the kidney, ureter and bladder, QB, and non-contrast computed tomography, CTUT. The operative technique of the flexible ureteroneoscope is considered more safe for either patient and even surgeon. Short brief for the operative technique: patient were placed in the dorsal dichotomy position. Access to the ureter was achieved with a straight floppy-tipped guide wire under the fluoroscopic monitoring, followed by a 7 French ureteral catheter, which was passed over the guide wire. Then a retrograde pyelogram will be performed for the assessment of the pelvic calcaneal system anatomy. Dilatation of the ureter using Teflon ureteric dilators till 14 French, then introduction of the axis sheath, followed by the application of the single-use digital flexible ureteroscope. After reaching the renal pelvis, systematic inspection of the pelvic calcaneal system to identify the stone endoscopically under saline irrigation, and then fragmentation of the stone done by the laser fiber. After fragmentation of the stone, the big fragments were finally removed using the tipless Nilton basket. At the end of the operation, a double J stent should be applied routinely. This video will show the difference between the start of the operation and the end of the operation. Results: 55% of patients are stone-free with percentage of 91.6%. As regards stay, the operative time depends, but it around 60 to 90 minutes all over the patients were done in our department. Hospital stay around 1 to 2 days, and in such condition, in certain patients, patient is discharged at the same time of the operation. Comparison between study groups regarding major complications such as bleeding, 0%, residual stones or stone migration, around 2 patients with percentage 3.33%, pelvic calcaneal system injury, 0%, fever, around 5 patients from the 60 patients with percentage of 8%. Conclusion: flexible ureteroscope is an acceptable alternative in the management of the renal and upper ureterorenal stones, more safe with minor complication and short stay, but it needs an extra procedure to remove the double J stent. Generally, before taking the decision of surgery, we must put in consideration many factors such as stone size, distribution, hardness, body mass index of the patient, presence of comorbidities, hospital equipment, and finally, surgeon experience. Thank you.
ثانك يو دكتور محي. ايه يعني تعتبرها كونتر انديكيشن انك انت تشتغل باليوتروسكوب فلكسبل يوتروسكوبي؟
يعني الحقيقه لو الحاجه الوحيده اللي انا شفتها في المستشفى عندنا لو انفكتد يعني يوروسبسس ستونز، يعني لازم باجل بوستبون البيشنتس الدبل جي الاول تو ريليف الاوبستراكشن ده او اليوروسبسس ده، بعدين ابروسيد ان سكند ستيج.
لا يعني هل الستون سايت او الستون يعني في كلوزد دايفرتيكولم، في كلوزد كيلكس؟
لو كلوز طبعا كيلكس مش اسيسبل، ديفينتلي هيبقى difficult to done الفلكسبل يوتروسكوب. بس حاليا السايزز ما بقتش حاجه تاثر جامد، لان انا شفت حالات ستونز 2 سم 2 سم ونص تاج هورن ستونز وبتخلص، وساعات بنضطر نخلصها او ساعات بنخلصها على مرحلتين كمان على 2 سيشنز. يعني
ما قابلتكوش حالات يورتر مش دايليتبل ل 14 فرنش؟
ساعتها بنضطر نحط دبل، لا يعني بس لو حصل في ستريكشر او في حاجه ما خلتش الاكسس شيس يخش بنحط دبل جي for 2 weeks and redo the flexible ureteroscope.
Okay.
دكتور محي very nice presentation.
Thank you.
كنت بسأل على الثمان حالات اللي هم حصل لهم فيفر بوست اوبراتيف فيفر، هل كان في اي حاجه يعني سبيسيفيك للعيانين دول؟ يعني مثلا ما اشتغلتش باكسس شيت، ما كنتش عامل يورين sensitivity مثلا قبلها، هل في حاجه in common between these patients؟
يمكن one patient only هو اللي كان في culture، بعد كده اكتشفت ان في pus cells over 100، ودي كانت حاجه يعني later on خدنا بالها منها كويس، لكن الحقيقه بالانفستيجيشنز كده اكتشفنا الموضوع مينلي جاي في الاستيراليزيشن بتاع الفلكسبل نفسه. لما بدانا ناخد بالنا من القصه الريت اوف فيفر قل، بلس الدبل جي بوست اوبراتيف ممكن تكون هي احد الاسباب اللي بتسخن العيانين later on يعني.
I think there is one more reason for the possibility of infection. We always using high pressure
Yes, definite.
by the saline
Mm.
during the procedures. This is one of the most important reason to get infection.
Agree.
We have to take care of this.
Agree with your excellency.
متهيألي برضو حكاية الريوز بتاع الفلكسبل بالذات اللي متأجرين يعني هم الشركات اللي عايزة تحافظ عليه فبتعاقموا. If you want to reuse it, use plasma.
Can
بس اقصد حكايه انه يمسحوا بالكول وبتاع.
دي نقطة.
ده even the laser fiber هم عايزين الشركات اللي بتأجر دي تبقى عايزه تمسحه بس بالالكول بس. كل ده will add for
الحقيقة
infection.
ده كان سبب مباشر في الفيفر بتاعت العيانين في الأول خالص، قصة الاستيلايزيشن بتاعت الفلكسبل يوتروسكوب يعني.
طيب استكمالا للدكتور ايمن قاله موضوع الاريجيشن، اعتقد ان احنا اشتغلنا شويه حالات باريجيشن مش كونتينيوس، مش ببامب، مش باريجيشن. لما غيرنا الطريقه دي هل في حصل اي امبروفمنت في الفيفر مثلا؟
ما كانش في باك فلو عالي
صح كده؟
يبقى احنا كنترول القصه من عندنا احنا.
بننجكت اون يعني اون سبوت اون انترميتنت بسيرنج.
مش
بيبقى المساعد لا خالص. انا عاده ما بشتغلش ببامب خالص، ما بشتغلش بفلو، بفري فلو irrigation بسيرنج. الراجل اللي بيساعدني بيحقن ونيفر الفيلد مش ظاهر، تدي فلويد اقل طبعا، وفي نفس الوقت بنقلل الريت اوف انفكشن.
هو الانترميتنت irrigation فعلا فارق. انا برضو بقيت اشتغل بيه على طول. وهو لما نشوف حتى في التست اللي هي معموله بره، كان في اليوروبيان اخر مره كان في موديلز كانوا عاملين بامب ريجولار بامب شغاله، فبتبين وعلى موديل وبيشوف البريشر بيعلى ازاي. الريجولار بامب عشان هي شغاله irrelevant للسيستم، بيفضي مش بيفضي، البريشر كان عمال يعلى بطريقه عاليه جدا، لدرجه ان هم كانوا يعني التكنولوجي الجديده ان بنحط بريشر سنسور في الفليكسور عشان نعمل كده. الميزه بتاعت الانترميتنت irrigation ان هي بتدي فرصه للسيستم يديفليت، يعني بنستخدم شويه سيستم يديفليت نملى تاني، فاللي هو الكونتينيوس رايز في البريشر ده اللي هو بيعمل انترفازيشن ما بيحصل.
انا اعتقد اصلا احنا لو عندنا مانومتر في طول ما احنا شغالين في العيانين المناظير بتوعنا، لو عندنا هنتخض. يعني اعتقد انه البريشر لو اتقلب لحاجه مرئيه بالنسبه لنا احنا هنبطل حاجات كتيره احنا بنعملها. شكرا دكتور محي.
Our last presentation presented by Dr. Ashraf Satur, a novel minimally invasive technique in treatment of renal stones.
ده الرقم. اوكي، في عندنا اي Dear Chairman, thank you for my invitation for our lecture today, novel minimally invasive therapy for treatment of renal stones. أنا أشرف محمد سطور, consultant lecturer of urology at Chance University. Nephrolithiasis is a major worldwide source of morbidity, affecting about 10 to 15% from world population. Percutaneous nephrolethotomy has prevailed over other more morbid techniques like open surgery in the management of renal stones. Actually, it is still considered the gold standard treatment of renal stones larger than more to 2 centimeter or lower calcium stones larger than 1 centimeter, offering a high stone fill rate after the first treatment in comparison with other minimally invasive lithotripsy techniques. Actually, standard PERC has minor complications and a high stone fill rate reaching about 93%. So why ultra mini PERC? With advancement of other modalities like ultra mini PERC, it becomes an option for treating renal stones with relatively minimal complications and lower hospital stay and lower cost. So what's the difference between standard PERC and ultra mini PERC? One of the most important differences between the various PERC techniques is the size of renal axis, which contributes to the broad spectrum complications and outcomes. Comparison between standard PERC and ultra mini PERC. Dilatation up to 30 French. Endoscopy used within standard PERC 26 French rigid nephroscopy, the ordinary nephroscopy, and the fragmentation device was pneumatic lice closed. But in ultra mini PERC, X sheath used, we use 14 French teeth and drug dilatation about 14 French, and we use the ordinary semi-rigid ureteroscopy 9.5, and the fragmentation device was Hormel laser lithotripsy. And this comparison between standard PERC, mini PERC, and ultra mini PERC and macro PERC, look, ultra mini PERC, the stone fill rate reaching more than 90% and transfusion not reported. What are the steps of ultra mini PERC? This is my article which talked about safety and efficacy of ultra mini PERC in comparison with standard PERC nephrolithotomy for management of renal calcium stones 1 to 2 cm in size. And this in brief is different steps in practicing ultra mini PERC. Drug dilatation was up to 14 French, and we used the semi-rigid nephroscopy, Carl Storzi medical instrument, and used the laser fiber 365 millimeter. And the track, after finishing lithotripsy, we will remove the X sheath, and the track was packed 2 to 3 minutes. And double J stenting or nephroscopy was depend on the surgeon preference. And this is our result. And when compare standard PERC with ultra mini PERC, we saw the stone fill rate in standard PERC, which exceeding 19% and was very comparable to ultra mini PERC, which was reaching 90%. Arab Journal of Urology also published ultra mini PERC nephrolithotomy versus standard PERC, published in 2017, and showed very comparable results between ultra mini PERC and standard PERC. And this stone fill rate, which in ultra mini PERC was 7%, stone fill rate in ultra mini PERC reaching or exceeding 90% and was very comparable to standard PERC, and p-value was statistically insignificant. So there is no difference between stone fill rate between ultra mini PERC and standard PERC, but transfusion rate was a very, very comparable and statistically significant when comparing ultra mini PERC to standard PERC. Now we are in the flexible era. So what about flexible ureteroscopy versus ultra mini PERC nephrolithotomy? This is an article published in World Journal of Urology comparing ultra mini PERC versus flexible ureteroscopy. And the result was stone fill rate in ultra mini PERC patients reaching 84, and very, very comparable to flexible ureteroscopy, which reaching 87, and statistically insignificant. And the complications were very, very comparable when comparing ultra mini PERC to flexible ureteroscopy. And this is the same article when and they take a conclusion from this article. He will focus on a very important thing in our country, which is the cost. The cost is significantly lower in ultra mini PERC than flexible ureteroscopy, which is a very, very important thing in our country. Just keep in mind that we are in a developing country. Finally, we should keep in mind that the gold standard method for treating renal stones with high stone fill rate is still standard PERC, although standard PERC can cause various complications and serious complications, including bleeding, visceral damage, and their frequency is relatively low. An appropriate alternative for standard PERC in treatment of renal stones is ultra-mini PERC with very low complications and shorter hospital stay, which make it safer. Surgeons must of comorbidities, patient preference, hospital equipment, surgeon experience, and operation cost. Thank you so much.
ثانك يو دكتور اشرف.
Thank you.
الاوبراتيف بروسيدور بتبقى فرق significant بين الاثنين، بين الستاندرد بيرك والميني والالترا ميني بيرك.
هي الفكره كلها بايه في الالترا ميني بيرك، هي يعني ترانزيشنال زون بين الستاندرد بيرك بالكومبليكيشنز بتاعتها والفلكسبل الكتروسكوبي، والمين سيجنيفيكانت تشينج اللي حصل ان احنا قدرنا نعمل حاجه كومبارابل للفلكسبل الكتروسكوبي ريجاردنج السايز اللي موجوده، والكوست بتاعتها اقل كتير عن الفلكسبل الكتروسكوبي، وده شيء في حد ذاته كانت نقله او فكره كويسه بالالترا ميني بيرك. وقدرنا كمان ننزل في الكومبليكيشنز شويه عن الستاندرد ان مفيش اي ريبورتس كانت موجوده عن الترانسفيوجن ريت.
لا انا بتكلم على الاوبراتيف تايم، عشان يعني الاوبراتيف تايم اللي بياخدوا الليزر فراجمنتيشن
مور الالترا ميني بيرك زي الستاندرد بيرك.
ده فاكتور مهم، لان اولا انت طبعا في الميني بيرك او الالترا ميني بيرك انت you have to fragment the stones to very short very small sizes.
Yes.
ده بيخليك الى جانب ان الليزر بياخد وقت اطول من النيوماتيك، لكن كمان بتضطر تصغر قوي لانك كده مش هتقدر تطلع الفراجمنتس دي.
نو
بيطول لك طبعا وقت عمليه قوي. هو طبعا يعني ايديالي طبعا من ضمن الحاجات المهمه في الميني بيرك البيدياتريك.
يس.
اللي يعني ده one of the main indication يعني الميني بيرك البيدياتريك جروب.
يس.
هو زي ما حضرتك كنت بتقول فعلا، هو التايم فاكتور هو فعلا زي ما اشرف بيقول هو في النص. يعني لو احنا بنتكلم على ستاج، احنا في البي سي ان ال العادي هناخد وقت اقصر، وفي الفليكسبل هناخد وقت اطول. يعني الالترا ميني بين البنين حاجه في النص فعلا. هيبقى اسرع من الفليكسبل في الستون الكبيره، لان احنا بنستخدم فايبر اكبر والفراجمنت كليرنس بيبقى احسن من الفليكسبل، وفي نفس الوقت هو اقل كومبليكيشن من الستاندرد بي سي ان ال، فهو كومبرومايز ظريف في الحالات اللي هي زي كده طبعا.
طبعا بشكرك على البرزنتيشن يا دكتور اشرف.
ثانك يو سو ماتش.
عندي بس سؤال. انت اصلا في وانت بتكسر using the laser, do you do dusting technique like the one for the flexible, ولا بتكسر الحتت مثلا in between زي ما انت وصفت العمليه بتاعتك؟
dusting is better.
ما هو dusting is better بس it will take much longer time comparable to the flexible urethroscopy. انا قصدي ايه؟ قصدي انه او حسب تخيلي يعني انه الالترا ميني بيرك الشيث بتاعك عندك فرصه شويه للفراجمنتس دي تنزل، على عكس الاكسس شيث بتاع الفلكسبل يوريتروسكوبي. يعني حتى باي جراف انت اولا كنت شغال سوباين ولا برون؟ برون.
انا بكمبير بين الستاندرد بيرك.
كويس. كنت بتخرج اي فراجمنتس من الشيث؟ يعني ده فرق معاك في الستون فري ريت ان كومبارابل للفلكسبل مثلا؟
هو الستون فري ريت هنا كان معتمد اكتر على الستون سايز. يعني احنا لما كنا شغالين على السايز بتاع الستون كان 1 to 2 سم سايز، الفرق ما كانش واضح قوي. لو احنا بنشتغل لارجر ستونز في ستادز ثانيه طالعه مور ذان 2 سنتيمتر، اعتقد ان هنا هتفرق كتير جدا عن السايز الصغيره، لان الوقت مش هيكون كبير ان حضرتك تقدر تكسر الحصوات الصغيره دي.
السؤال الثاني، فرق معاك الالترا ميني بيرك في الهوسبيتال ستاي؟ يعني
كتير.
انت اولا كنت بتركب نفروستومي ولا لا؟
لا انا ما بركبش نفروستومي دبل جي.
كله تيوبلس؟
اونلي وان كله تيوبلس.
intentionally كله تيوبلس؟
هو
انت عامل الاستادي بتاعتك ان كله يبقى تيوبلس.
يس.
طب لو حطينا تيوب في العيانين دول، يعني is the standard of care في الالترا ميني بيرك التيوبلس ولا في ناس بتحط تيوب عادي؟
اصل دي يعني في حد كان ناشر في العرب جورنال اللي هو كان حاطط تيوب جاست فور وان بيشنت فور انذر كوز، بس التيوب هنا يعني هادرين وات.
لا مش تو جين وات، لا انا بسال لما نيجي نقارن الهوسبيتال ستاي بالستاندرد بالالترا ميني بيرك.
one of the advantage of ultra mini perk اللي ما فيش عندي نفروستومي وبالتالي شورتر هوسبيتال ستاي، ده one of the advantage.
ما هو الفكره انه الستاندرد برضو ما فيهوش تيوب، في ناس قالوا انه ما فيهوش تيوب.
ده موديفيكيشن من الستاندرد.
فيري نايس. انا بتكلم لو قصادك الاثنين والاثنين حطيت لهم تيوب، هتفرق معاك في الهوسبيتال ستاي ولا لا؟ انا ده سؤالي. لو اضطريت تحط لو انت ستاندرد اوف كير بتاعك انك بتشتغل ميني بيرك الترا ميني بيرك بتيوب وستاندرد بتيوب، هتفرق معاك ولا انت اصلا اللي فادك ساعتها انك شغال تيوبلس مش شغال الترا ميني؟
اصل هنا دي التيوب حضرتك هتحطها في الستاندرد بيرك فور درينج فور تامبونيدنج، حضرتك في الالترا ميني بيرك التامبونيد وات very minor trauma، الشيث بتاع حضرتك very small، no need for nephrostomy in my opinion in ultra mini perk.
مش بس تامبونات، يعني هو برضو ده احد الدرينج، انت مش دايما بتحتاج تيوب كتامبونات يعني، لكن الفكره انا شايف انت في الستادي بتاعتك انت كاتب الهوسبيتال ستاي المتوسط 2.2 والثاني 3 something. هو الفرق 1 day زياده يعني بتاع الانبوبه بس فهو الانبوبه لا، ما هو لو ما فيش انبوبه وتيوبلس وحاطط دبل جي you don't need to stay for 2 days.
today هنا بي كان وال 3.2 كانوا statistically significant يعني في الريزلتس بتاعتنا.
على البلد يعني
احنا مش بننقد الشغل، احنا بنتناقش معاك في انه هل النتائج كان ليها علاقه بالالترا بالمينياتشرايزيشن بتاع الشيث ولا العلاقه بانه مفيش تيوب؟ انا بس بحاول اريز الحته دي.
انا شايف او اللي حصل معايا في الاستادي دي ان احنا ما كانش اصلا عندنا احتياج ان احنا نحط تيوب نظرا لصغر حجم التراك، وكان الباكينج بتاعي اللي انا بعمله 2 to 3 minutes is very sufficient for hemostasis.
تمام.
هو لو مستشفى خاص هتقعد يوم واحد مش
هو يعني
في ناس برضه بيكونوا قاعدين يوم واحد بس.
هو ده اعتقد ان هي البوينت، اللي هو انت مش بتحط تيوب وانت بتعمل بروسيجر مينيمالي انفيزيف، فليه من العيانين ما تخرجش فعلا تاني يوم؟ يعني احنا المفروض ان في حالاتك فعلا ان العيانين كلهم وان داي، لان هي فعلا تكنيك كويس، بتعمل درينج حلو، مفيش حاجه متوقعه. ف
most of my patients خرجوا فعلا تاني يوم. بس في ناس هم اللي طولوا، وده اللي اداني البرسنت في الاخر خالص اللي هي 2.1
بالظبط. يعني يمكن هو بس عشان هو لسه تكنيك مستمد من البي سي ان ال الستاندرد، فالمايند سيت بتاعت العيان قلقان وممكن
عشان السنه الجايه.
ثانك يو.